I'm here at the ICA meeting with Stephanie Prendergrast. We interviewed Stephanie for the Doctors Forum in the summer 2010 ICA update, so don't miss that. Stephanie has been a leader in developing techniques for pelvic floor therapy for people with IC. And so we have a chance to ask her what techniques have worked best for IC patients with high-tone pelvic floor dysfunction and how things changed in your career.
So for patients dealing with interstitial cystitis, the literature has begun to reflect that there are a lot of myofascial impairments that tend to accompany patients with symptoms of bladder pain and general pelvic pain. So we're basically seeing the evolution of connective tissue manipulation as well as manual therapy techniques directed at the pelvic floor and external muscle groups that are associated with the symptoms of interstitial cystitis or painful bladder syndrome. The techniques can be internal and external, and the focus has been more on manual therapies versus just things like home exercises and biofeedback, which can also be complementary for down training and helping patients become more functional.
Oh, great. And for internal techniques, you know, a lot of patients are afraid of having that done. What would you tell them about whether it hurts, whether they can stand it, and how helpful those things are?
It's completely understandable that patients may be nervous about having internal therapy. Hopefully a patient undergoing manual internal therapy is going to a physical therapist who is quite trained, and hopefully it's reassuring to that patient that that therapist has been working within the medical community doing these types of techniques repetitively over and over again during the day. At times the techniques may be uncomfortable, at which point it's always a patient choice if they need to back off or continue with the therapy. It's not uncommon for a patient to have a brief increase in soreness following the therapy, but if the therapist helps the patient understand that an increase in soreness as a result of a therapy is different than an increase in their symptoms or pain, hopefully a common understanding will help the therapist, the patient, and their provider work together to come up with a successful treatment plan.
Now, I understand that you use some techniques that some physical therapists don't use in terms of manipulating the skin. Could you explain what you do and why that helps?
Absolutely. So one of the primary components of our treatment plans for patients with IC or PBS involves connective tissue manipulation. And we really find it relevant that the tissues below the ribs all the way down to the knees and sometimes further are actually involved in the symptoms that patients have. It's documented in the literature that there is referred pain, and so sometimes connective tissue issues in areas that are distanced to the site of the bladder are actually pretty influential in creating and contributing to the bladder symptoms. So we do connective tissue manipulation and myofascial trigger point therapy in the muscles of the abdomen, the buttocks, the thighs, and sometimes even down into the lower extremity and foot.
Oh, thanks, Stephanie.